Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And today I'm going to talk about atypical presentations in disability, or, as I like to say, when the disease hasn't read the textbook. As usual, everything I say represents my own opinions based on my own experience and study, and not the opinions of the Social Security Administration or any other medical body. I was prompted to do this by a patient I saw recently, a middle-aged man who was applying for Social Security disability. I'd read some of his medical records before I saw him, and they indicated he'd had recent neck surgery for cervical myelopathy. When I met him and took his history and examined him, I was quite surprised to find out that he had no neck symptoms, no pain or stiffness, and no arm symptoms. He had no pain in his arms, no numbness, no weakness, no clumsiness, no difficulty with fine movements. All of his symptoms were confined to his legs. There had been some delay in diagnosing his condition, and I suspect that his atypical presentation was responsible. If you read the textbooks, cervical myelopathy presents predominantly with symptoms in the arms and less with the symptoms in the legs. That brings me to one of my pet peeves, which is the use of terms upper extremities and lower extremities in medicine. I have no idea who thought it would be a good idea to use 8-syllable terms when we have a perfectly adequate 1-syllable term that everyone who speaks English and many people who don't speak English understand. It's like calling a spade a Homo sapiens directed excavation implement instead of calling a spade a spade. When I examined the man with cervical myelopathy, I found one thing in his arms. There was a positive Hoffman sign on the right side. As you recall, Hoffman's sign is seen by flicking the fingernail of the middle finger. Normally, there's no finger movement. With a positive Hoffman sign, the fingers flex. It's been called the Babinski sign of the arms. It's an upper motor neuron sign. I never used to test for it, but having started to do so recently, I've found quite a few positives, and it's now becoming part of my routine neurological exam. In the legs, this man had mild weakness of both legs, negative Babinski sign, and a very positive Romberg sign. He fell with his eyes open when his feet were close together, and he had some difficulty walking with a sort of ataxic gait. So that was quite an atypical presentation. Atypical presentations can be quite a problem in any part of medicine. There's a statistical riddle, which is that if you see something frequently, you will likely see an atypical presentation. If you see something very rarely, you will likely see a typical presentation. Conditions of the spine are the most common complaint in Social Security disability exams, so you must be prepared for atypical presentations. It's important to rule out atypical presentations before labeling a patient a hypochondriac or malingerer, something I've come close to doing in the past and may actually have done and be unaware of it. Signs on physical exam that lay people are unaware of or that are impossible to feign are useful for differentiating hypochondriasis, malingering, and atypical presentations. For example, the Babinski sign is rarely known by lay people. Likewise, abnormal deep tendon reflexes are impossible to feign, as I explained in my most recent video. If you're considering that the patient's complaints are functional and you find one of these signs, you must reevaluate your opinion. I'm going to give an interesting example of a patient who was thought to be functional, who actually had a fatal condition. This was a middle-aged man who checked into the emergency room in the morning with a chief complaint that he had a bird in his chest. The emergency physicians were busy and they thought this patient was a kook, and so they put his chart at the bottom of the stack and went and saw the usual chest pains, anaphylactic reactions, and traumas. After several hours, one of them finally decided they'd see this silly patient and went and interviewed him. It turned out he was a very intelligent, middle-aged man, upper middle class, and he had awoken that morning with a sound coming from his chest that sounded to him like a pigeon cooing. He had no pain whatsoever. The patient's level of education and intelligence is significant for the history. Some patients are inarticulate and are unable to use terms we normally associate with their condition. Some patients, such as this man with the bird in the chest, are overly articulate. His description was very accurate and evocative, but it was not what an average person would complain of. When he was examined, he had a very loud heart murmur. It turned out that he had a grade A aortic dissection, a condition that's basically uniformly fatal if not treated surgically. Luckily, he was diagnosed in time, had emergency surgery, and did fine. Here's an example of seeing atypical presentations of common conditions. When I was an intern, I knew that if abdominal pain was not located in the right lower quadrant, the etiology could not be acute appendicitis. I'm now in my 43rd year of practice, and I've seen many cases of acute appendicitis, the vast majority presenting with right lower quadrant pain, but I've also seen acute appendicitis present in the right upper quadrant and the left lower quadrant. If I practice for another 43 years, I'll probably see it present in the left upper quadrant as well. Here's some more examples of atypical presentations. I had a young man, a weightlifter, present with chest pain. His pain was sharp and stabbing and was exacerbated by movement and breathing. On examination, everything was normal. What struck me about him was he didn't seem the sort of person to come to the emergency room with a trivial complaint. So I decided to get a few investigations. Imagine my surprise when his chest x-ray showed very large mediastinal swelling. It turned out that he was presenting with a lymphoma. In another situation, I almost diagnosed a patient with functional illness. I had a woman in her mid-adult years come in the emergency department complaining of headache. She had all the typical signs of hysterical neurosis, including wearing a bright red dress, which is called the Little Red Riding Hood sign. She told me that she'd been having migraine headaches for a year, that she'd been treated by a very competent family physician, and had no other symptoms. The emergency department was very quiet that day, so for some reason I did a complete, almost intern-level neurological exam, and everything was completely normal. After some deliberation, I decided to get a CT scan of her head because her family physician had never done one. I was astounded when I saw it. There was impressive hydrocephalus, and it turned out that she had an obstructing third ventricle tumor. Finally, I'll give you the example of my best friend from childhood. He developed diplopia when he was around 20 years old. He saw several physicians, all of whom diagnosed him with a functional illness. Finally, he was referred to an ophthalmologist, and it turned out that he had a malignant pinealoma, which at the time was 90% fatal. Luckily, he was one of the 10% who was cured with radiation. This brings me to a very important point. Real new onset diplopia is serious illness until proven otherwise. Most patients who complain of diplopia don't have it. They merely have blurred vision, which is a far less serious complaint. You need to actually ask the patient, when they look at one thing, do they see two instead of one? And if they have real diplopia, regardless of the rest of their exam, they need investigation and probably referral to an ophthalmologist. Finally, a very good piece of advice that I got from one of my mentors early in my career. Whenever patients present, regardless of their complaint, always ask yourself this question: what is the worst thing this can be? Then rule that out. Well, I hope this has been helpful, and as usual, always remember, if it happens, it's possible.